From the JAMA Network, this is JAMA Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinion featured in JAMA.
Hello, I'm Dr. Christopher Muth, Deputy Editor at JAMA, and I'm here today with Dr. Diederik Dippel, Professor in the Department of Neurology at Erasmus University Medical Center, Rotterdam. Today we'll be discussing two related original research articles published in JAMA. These articles report the results of two randomized clinical trials, the post-UK and post-TNK trials, which were studies of adjunctive intra-arterial thrombolysis after successful endovascular thrombectomy for patients with acute ischemic stroke. Dr. Dippel was also a co-author of an editorial published in JAMA that accompanied these two articles. Thank you for joining us today, Dr. Dippel.
Hi, thank you.
Most listeners are probably familiar with the general treatment approach for acute ischemic stroke. Typically, if patients arrive early enough and there aren't contraindications, they'll receive intravenous thrombolytic. And if they have a large vessel occlusion and they meet certain criteria, they may also receive endovascular thrombectomy to have the clot mechanically removed. But these particular studies that we're discussing today involved another intervention after successful thrombectomy, which was administration of intra-arterial thrombolytic after the thrombectomy. So to begin, can you explain what the rationale was for administering intra-arterial thrombolytics after successful thrombectomy?
Endovascular thrombectomy has greatly improved the outcomes of patients with an ischemic stroke caused by a large vessel occlusion intracranial. However, a significant number of patients do not recover despite what appears to be a favorable reperfusion on imaging conducted during the procedure. And one explanation for this phenomenon is that although the large vessel has been recanalized by the thrombectomy, the more distal, smaller vessels and capillaries that are more difficult to assess on current imaging modalities might not be open again. These hypothetical occlusions, which we cannot see very well in the microvascular circulation, could, for example, be caused by new microthrombi or small fragments of the main thrombus. This is rather hypothetical, and we could certainly need more large animal studies of this phenomenon to guide our research. Administering intra-arterial thrombolytics could help dissolve these specific clots and aid the reperfusion of the affected area.
And prior to these two studies that are published in JAMA, can you tell us what's previously been known about the use of intra-arterial thrombolytics after thrombectomy, or what previous studies have been done?
Well, there were several studies, one RCT, which was published in JAMA, by the way, and several observational studies, and they showed promising associations between intra-arterial thrombolytics and functional outcome, as well as mortality. The observational studies were combined in a meta-analysis. It has been summarized in a paper by Chen in Stroke in 2021. These kinds of studies are prone to selection bias, of course. They showed at least an effect on functional outcome in the right direction, but was not statistically significant. But more importantly, the most well-known recent trial is the randomized trial, is the CHOICE trial, also published in JAMA a few years ago. This was a randomized placebo-controlled trial that examined the effect of administering intra-arterial alteplase versus placebo post-reperfusion on functional outcome and reported a positive result. However, the trial was terminated early due to unavailability of the placebo, and the investigators were unable to reach the pre-planned sample size. Importantly, the effect of the intervention compared to controls was only apparent for one dichotomization of the modified Rankin scale at 3 months, the primary outcome, 0 to 1 on the modified Rankin scale, and analysis of the shift over all 7 categories of the scale was not positive, and the effect on neurological deficit early after the intervention was neutral. And these points raised concerns for potential bias of the results. That's why we needed further studies. And the two trials published now aim to provide further evidence on this topic.
Yes, that trial previously published in JAMA, the CHOICE trial, had somewhat provocative finding of possible benefit, and so it was certainly important for this to be studied again in other trials. And that's why I think these trials were also of interest to JAMA. So now let's turn to these trials, the post-UK and post-TNK trials. They tested two different intra-arterial thrombolytics. One was Urokinase and the other was Tenecteplase. But otherwise, these two studies were basically trying to address the same clinical question in terms of whether there's benefit of intra-arterial thrombolytic after thrombectomy. They enrolled patients, again, with large vessel occlusions in the anterior circulation. Patients who had received IV thrombolytic before thrombectomy were actually not included in this study, I think due to concerns about potential bleeding risk. So these studies just had patients who received thrombectomy and had successful reperfusion, and then they were randomized to either an intra-arterial thrombolytic, one trial was urokinase, the other was tenecteplase, or nothing additional after the procedure. And can you tell us what the top-line findings of the studies were?
Yeah, well, the same primary outcome as in the choice trial.
Yeah, that was the modified Rankin of 0 to 1 at 90 days, which is essentially considered an excellent functional outcome without significant disability.
In contrast to the choice trial that we just discussed, these studies did not find statistically significant benefit on the primary outcome or on the secondary efficacy outcomes. So they didn't find evidence to support the addition of thrombolytics is beneficial in the treatment of patients who underwent thrombectomy for a large vessel occlusion. But, there's a but, as you described, the authors chose a dichotomized version of the MRS as a primary outcome. This is still common practice in stroke research. However, when outcome measures such as the MRS are dichotomized, you lose information and the results are less nuanced. What we want to see is consistency of treatment effects on the secondary outcomes. In this case, the authors also reported another common dichotomization of the MRS, which is 0 to 2 versus the rest. And they performed also ordinal regression, which summarizes the shift over all categories in one measure. However, both measures didn't show a significant effect. This was also the case in the effect analyses on neurological deficit measured with the NIH stroke scale at 1 and 7 days. So that was a bit disappointing.
Yes, and so I guess that sort of leaves us thinking about, well, what are we to make of these findings? I think for the primary outcome, which was the modified Rankin scale score of 0 to 1 at 90 days, the adjusted risk ratios for these two trials, it was 1.13 and 1.15 were the point estimates, but as you mentioned, they weren't statistically significant. What do you think the next steps are for clinical practice?
The two trials should formally be considered neutral, certainly not negative. I think the results of the choice trial were very difficult to interpret because it was terminated prematurely and the effect on outcome was not consistent. And that's very important. I think you should always try to have consistent outcomes over a number of outcome measures. So the twin trials in JAMA did include a predetermined number of patients. They were finalized as they should. And I think they didn't provide sufficient evidence to do anything now. But if you combine the results, there's a thing. All the three trials used different thrombolytic agents, tenecteplase, urokinase, and alteplase. But I think that the difference between the three drugs are minor because of what we know from previous trials. And I think we should combine the evidence from the three trials in one meta-analysis, as we did in our editorial. And even then, the effect is not statistically significant. So the effect is probably smaller than we first thought, and maybe more trials are necessary. The nice thing is that all effects are in the right direction and are consistent over several outcome measures. So that gives hope.
So it sounds like these findings are not something that should be done in clinical practice at this point, but perhaps there's a way to look at this in future studies.
Yes, I expect that we will see results of more similar trials in the near future.
Mm-hmm.
And I hope many of the physicians who are treating these patients will contribute to this kind of research. And the point is that the treatment is very easy to administer and not expensive. And the non-significant effect in the trials is direction and not too small. So I have hope that this will turn out favorably when we have more evidence. All I can say now is that we eagerly await the results of the ongoing trials.
All right. Well, thanks very much. Is there anything else you think that we need to cover about these studies or anything else you want to touch on?
I'd like to mention that the treatment was very safe. So that's not a concern.
Yeah, that's right. They had primary safety outcomes, 90-day mortality and symptomatic intracerebral hemorrhage showed no significant differences. So that is important to note. Yeah.
Yes.
All right, great. Well, thank you very much for joining us today to talk about these interesting studies. And thank you also for writing an excellent accompanying editorial.
Thank you.
I'm Dr. Christopher Muth, and I've been speaking with Dr. Diederik Dippel about 2 articles and an accompanying editorial about intra-arterial thrombolytics after endovascular thrombectomy for acute stroke. You can find a link to the articles in this episode's description. This episode was produced by Shelley Steffens at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.